live stream. Um, just as an update, I realize you guys probably know that I am not, in fact, Mark McDonald. I am one of the adult executive medical directors, and I'm pinch hitting for Mark because he is out of town. But we want to go ahead and get into this live stream today that I think is going to provide a lot of good education. So we appreciate you joining, and everyone will receive a link following the program for an evaluation. You can also use the QR code that will be displayed following the live stream today. Now it's time for our speaker, Dr. Brad Thrasher. Brad is an associate professor in pediatrics in the Division of Endocrinology at the University of Louisville School of Medicine. He serves as the director of the Christensen Family Sports and Activity Program for the Wendy Novak Diabetes Institute. Additionally, he serves as pediatric medical director of the Wendy Novak Diabetes Institute. He enjoys partnering with patients and families who live with diabetes and empowering them with tools and knowledge so that they can fulfill their dreams and aspirations. Thank you for joining us today, Brad.
Perfect. Thank you, Dr. Jennings, for having me. Well, guys, we will get started. I think I need to share my screen. I believe y'all can see my slides now. Um, so it is a pleasure to be here with you all today. Like I said, I'm going to talk a little bit about just type 1 diabetes in children, some that you probably already know, and then hopefully some will be some new stuff as well. So we'll dive in. I'll start by saying I have nothing to disclose. Oh, perfect. So here are learning objectives. We're going to talk about the common signs and symptoms at presentation. We'll understand our diagnostic test. We'll understand the staging of type 1 diabetes, which may be new to some people today, and then just kind of summarize our current treatment strategies. So, type 1 diabetes is a chronic autoimmune condition characterized by immune-mediated destruction of the pancreatic beta cells, which results in absolute insulin deficiency. It is one of the most common chronic diseases of childhood with an increasing incidence worldwide. Children typically present with polyuria, polydipsia, weight loss, and often are admitted in DKA at time of diagnosis. T1D or type 1 diabetes can truly develop at any age, but there are peak periods in children, typically between the ages of 4 and 7, and again between 10 and 14-year-olds is where we see a lot of people diagnosed. Management requires lifelong insulin therapy delivered either through multiple daily injections or an insulin pump, along with glucose monitoring, healthy nutrition, and regular follow-up. Patients typically see us about every 3 months. So, that is a lot to ask of families. Optimal care emphasizes maintaining glycemic targets to reduce the risk of both acute complications such as hypoglycemia and DKA, as well as your chronic microvascular and macrovascular complications. And then during this time, we're also trying to support normal growth and development and the psychosocial well-being for our patients as well. So now that we have our overview, we'll kind of dive in. So this is a slide that I stole from the SEARCH trial. And the SEARCH trial, it started in the early 2000s, and it's looking at the prevalence, the incidence, and complication of diabetes in those under the age of 20 living in America. And what this is showing is we have kind of our blue bars from 2001, and then our yellow bars representing 2017, that the prevalence of type 1 diabetes is increasing in our pediatric population. As of 2017, 215 per 100,000 youth were living with type 1 diabetes, which was equivalent to roughly 1 in every 500 young people. Back in 2017, about 364,000 Americans under the age of 20 were diagnosed with type 1 diabetes, which represents probably about 0.5% of our population. Not only is the incidence and prevalence of T1D increasing here in the States, Worldwide, there's estimates that 1.2 million children and adolescents under the age of 20 have been diagnosed with T1D, and we've been seeing a steady uptrend in those numbers as well, or I should say in the prevalence over the last 3 decades. This next study that I'm showing here, this was a self-reported study of the prevalence of type 1 diabetes that was published in 2024. And it actually showed higher numbers than what search showed in 2017. If we're looking at self-reported incidence of type 1 diabetes, this study concluded it was 1 every 250 use in the US. Now, granted, they were looking at under 18 to not 20 were thought to have type 1 diabetes. And then the last kind of incident slide I'll show you, it was published last year through Diabetes Care, which is the American Diabetes Association. And this is data out of Germany. And it was looking at incidence trends dating back to 1987. And what we're seeing here is that the incidence has increased. There's been certain periods in time where we've seen the incidence increase and or increase more rapidly and then kind of come back to a steady state. But in all age groups that they looked at, the incidence increased, but we saw a higher increase, or they saw a higher increase in ages 10 to 14. So, I think what this data is showing us is that, we're having an upward trend, which highlights a growing public health burden for those living with type 1 diabetes. Why we're seeing these trends, research has yet to truly identify that cause. I mentioned earlier that the incidence is increasing worldwide. Current data suggests the incident increase is about 2 to 5% globally annually. There's still that peak onset in the pediatric population in ages 4 to 7, and we think that has a lot to do with more environmental triggers, infections, kind of pushing kids or triggering that autoimmune response and kind of pushing them over the edge. And then that other peak in that 10 to 14 age group with more puberty related changes with making more hormones that are just cause insulin resistance that push people over the edge at that point. Currently in the pediatric world, about 85 to 90% of those living with diabetes do have type 1 diabetes. There's other forms of diabetes. You can have type 2, medication-induced diabetes. There's genetic forms of diabetes, but still in the pediatric population, type 1 is the vast majority of the cases. And again, it occurs in all ethnic groups, socioeconomic groups, and it's increasing in all these groups. We know there's genetic susceptibility to those that are diagnosed with type 1 diabetes. A lot of HLA genotypes have been associated with type 1. We think there's environmental triggers as well, whether that's, certain infections, through enteroviruses, whatnot. There's people looking at the gut microbiome currently to see if any changes there could be triggering the cause for type 1 diabetes. There's even people looking at vitamin D deficiency as a potential trigger for type 1 diabetes. We do know it's an immune-mediated process, but we've still not figured out the cause as to what tricks the immune system into starting this destruction. And once that destruction starts, it continues. And typically, when we get to about 40 to 65% of beta cell mass reduction, that's when hyperglycemia develops. And then, like I said, it's just that kind of a progression onward. Everybody progresses at a different rate. Younger children typically go more rapidly in that beta cell loss than older children or adults do. We'll get to this in a minute, but we know like the more antibodies you have, the more rapid the loss of the beta cells. So, we've learned a lot with the pathophysiology, but there's still a lot left to determine too. I put this slide on here because family history is a question that we always ask about when we're seeing patients. And we do know that if you have family members with type 1 diabetes, you're more at risk for the development. Uh, I find these stats kind of interesting. If you have no family history, you have about a 0.4% chance of developing type 1 diabetes. If you have an identical twin, so a clone, if you will, it's still not 100%. About 30 to 50% is what we're seeing in the research. If you have a sibling, I'll say 8 to 10%. Dads who have offspring have a higher risk of their children developing type 1 diabetes than moms who have children. The dad's risk is about 5 to 7%, where the mom's risk of passing on is about 3 to 4%. So we know there's this family component here, but still the vast majority of the cases at diagnosis, there is no family history. Typically, it's like research shows us there's about 90% of cases have no family history of type 1 diabetes. But knowing the family history can be very beneficial, especially in the world today, when we're getting into research programs that will screen for type 1 diabetes. So other risk factors, I mentioned earlier, these HLA genotypes. We know that they're the HLA, there specific HLA DR and DQ genotypes, which are found in about 90% of children with type 1 diabetes. We know that if you have one autoimmune disease, you're at risk for the development of other autoimmune diseases. And in those with like Graves' disease and pernicious anemia and celiac and vitiligo, their risk for developing type 1 diabetes is higher than the population living without those diseases. And then, like I said, there's been a lot of research looking at these environmental factors or triggers, if you will, as the enteroviral infections specifically have been looked at. Is this a trigger that pushes people over the edge or tricks the immune system into starting this process? In the last, I'll say, probably 5 to 10 years, a lot of people have started looking at the gut microbiome to see if there could be anything there. So. Um, I hope one day we can figure out why this process gets started, but I think that's the process with the problem with a lot of autoimmune diseases is truly figuring out the why behind it. Mhm. Sorry, guys. So the classic symptoms that you see with diabetes is what you were taught in medical school, the three Ps, the polyuria, the polydipsia, the polyphagia, and then along with that comes your weight loss since you're burning through your fat stores. But before we get to those classic symptoms, sometimes or oftentimes, kids can report they're just, more tired than normal. Some kids will even report blurred vision. We're having these episodes of where, yeah, their blood sugars are spiking, but then they're, able to still come back down on their own because they're still able to produce enough insulin to do that. You can even see a increased risk, especially in females, of yeast infections just because of the spilling of the sugar through the urine. I probably shouldn't have put fruity breath there because if we get to fruity breath, you're in ketosis and you're more than likely in DKA. So you're going to be going to the ICU there. In younger children, a lot of times we see irritability or just behavior changes. It's very common for like, I'll say the 2, 3, 4, even 5, age group for parents to be like, my kids just, the behavior's just been so terrible and so off. It's just been very different to what it's been in the past. And a lot of times, when we get blood sugar stabilized, parents report, yeah, the behavior has improved dramatically. In the younger kids too, they can have, poor weight gain or even weight loss. And then, like I said, then we get more to that polydipsia again with the excessive thirst, urination. And then when we get to the vomiting and the abdominal pain, we're at high concern for diabetic acidosis. And with DKA, it is a life-threatening acute complication. The mortality of DKA in children in the United States is truly quite low. It's generally reported between 0.15% and 0.35%, and it rarely exceeds 0.5% in any developed country. But despite this, overall low rate, DKA still remains the leading cause of mortality in children with type 1 diabetes. And I think, we've all somewhere along our career heard a story, around this time of year when we have a lot of flu going through the community or another virus where, a family taking care of a kid just thought their kid had the flu because they were throwing up and not feeling well. And they didn't take them to be seen. And then they find their kid, unconscious in their bed. And unfortunately, that has led to, cerebral edema and, terrible consequences for a few patients along the way. So, if the kids continue to throw up, you guys know that. But going back to DKA, it is very common at initial diagnosis because again, there's most people have no family history. Most of the times when people are diagnosed here in our hospital, one of the common remarks made by families like, "I had no idea to think diabetes, like it wasn't even on my radar," because they just don't know. And then we know kids, the younger you are, there's a higher risk for DK there because again, there's just that more rapid destruction of the beta cells, leading to that more kind of that rapid decline of hyperglycemia. And again, DK is a urgent, critical condition where, you're going to be admitted to the ICU for IV fluids and IV insulin to correct that acidosis before we start you on subcutaneous insulin. And the classic signs of DKA is, vomiting, abdominal pain, nausea, the Kussmaul respiration is that rapid, deep breathing, trying to blow off that extra acid. And then, altered mental status can be seen as well. And the cause of death in these kids, we get cerebral edema, which leads to that mortality and morbidity. So when you have a kid that comes to, the clinic, gym peds, and they're saying things that make you think, oh, could this kid have, diabetes? A focused history and physical exam, goes a long way. You want to assess the hydration status, their mental status, and then truly doing what I think are, relatively cheap, easy tests to do, just point of care test, can oftentimes lead to the diagnosis. Like if you're able to do a point of care glucose in your office to see what that is. If you don't have a point of care glucose, just doing a UA to see is there glucose in the urine because our renal threshold for glucose is 180. So, if we're having hyperglycemia, we're going to see that glucose there. And and then once we know if we have hyperglycemia, then the next step is this kid in DK or not? And checking for urine ketones can help us answer that question. So the diagnostic criteria for diabetes is if you do a random plasma glucose and it's greater than or equal to 200 with your classic symptoms, the polyuria, the polydipsia, the polyphagia, and the weight loss. Or you could do a fasting plasma glucose and get greater than or equal to 126 with your symptoms. Could do a 2-hour OGTT with greater than or equal to 200, or any A1C that's 6.5 or higher. Now, per the American Diabetes Association, if you don't have the classic signs and symptoms, you do need to repeat these tests, or you need to repeat the same test on a different day, or do another test to get a result that's consistent with diabetes if you're doing it on the same day. So getting like a random plasma glucose with an A1C, if possible. And then once we have found somebody or diagnosed somebody with type 1 diabetes, when they get sent to us, the first question that we're asking is this person in DKA or not? So, a lot of times our workup, we're getting renal functional panels to assess their bicarb status. We'll get that A1C at baseline to see where that's at. We're either getting urine or serum ketones there as well. We do get a C-peptide level that's not needed for diagnosis, but can be helpful if you have a case that you think it could be a genetic type of diabetes, or even if you're thinking type 2, because a lot of times you'll see that C-peptide elevated and insulin resistance. And then we're getting diabetes specific antibodies. And there's been a lot of talk with the antibodies over the last several years. Um, as we're getting newer drugs that can catch people at different stages that could potentially delay the need of insulin. So let's spend a little time just talking about antibodies. Classically, there are five antibodies that we send. There are other antibodies, but they're typically research related. But GAD tends to be the most positive in children and insulin as well. But we also send islet cell, the zinc transporter 8 antibody, and then the I2A. Um, you can have diabetes with one antibody. We see that every day. Not every day, but we see that very often at diagnosis. A child comes in with an A1C of 10, their blood sugar was 300, they're in DKA. We send all the antibodies and only the GAD comes back positive. So, one antibody is all it takes for it. But with the world of kind of screening for diabetes, kind of where the ADA is at right now, is if you find somebody that has two or more antibodies, their risk factor or their risk to develop type 1 diabetes in the next 10 years is 70%. And if you have two or more antibodies, you can tell an individual their lifelong chance of developing type 1 diabetes is 100%. Research has also shown us again that the younger the age of the patient, when you find these antibodies, the more quickly they're going to go on to need insulin. And the more antibodies that are present, the more rapid destruction of those beta cells and the quicker the need for insulin. So we send antibodies to confirm that autoimmune etiology because again, it could be a genetic form, it could be a type 2. It helps with the staging of diabetes, and which can be useful in research and screening programs. So staging of diabetes might be a new term to some people, and this probably started back in, I'd say, 2015, around that area through research that was being done, where they were looking at different drugs that could delay the progression of that destruction. So there's three stages to type 1 diabetes. Stage 1, you find two or more antibodies in an individual, but they're euglycemic. Blood sugars are perfectly normal. They're asymptomatic. They're going about living life without any problems. Stage 2, the antibodies, two or more, are there, but now we're starting to have some dysglycemia. You're fasting, you might be waking up, over 100, 112, 115, but you're not in that diabetes range of fasting. When you eat, you might be getting some spikes, 180, 190, you might hit 200 or so, but your body's going to bring itself back down. Typically, you're still asymptomatic at this stage. And then stage 3, this is when the symptoms, the polyuria, the polydipsia, the polyphagia, show their ugly head. And this is when most people are diagnosed, because at this stage, you have to start insulin to get the blood sugars back to within normal range. So this is just kind of a word form of that chart on the last slide. And then the progression rate is variable. Again, I know I've said this before, but again, the younger you are and the more antibodies, though, the more rapid that progression. And then the C-peptide, should have put this a little bit earlier in the presentation, but this is just a marker of the endogenous insulin production. It can be very helpful when we're dealing with atypical cases, through like genetic cases, or you have antibodies are all negative and somebody's still making a C-peptide a year after diagnosis. A lot of times we'll send MODI or genetic testing on those individuals, but again, not required for diagnosis. And then, like I said, not all children have to have type 1 diabetes. The vast majority do, but there can be other causes. So we always want to think about those as well. And then going back to the stages here, in stage 1 and 2, these kids are asymptomatic. The antibodies are there, but the world has changed that now. 10 years ago, if you found somebody with antibodies, you could prepare them for what was to come. But now there's one FDA approved medication and there's others in research which will slow the progression to needing insulin. So there are screening programs, multiple screening programs in America. There's screening programs in Europe. There's screening programs in Australia. Because again, there is this incidence of type 1 diabetes is increasing globally, and truly we're trying to prevent DKA. We want to try to catch people early so that we can prepare and educate them on, about their health and what's to come. And we're trying to keep them out of DKA, and we're trying to maintain, as tight as blood sugar control as we can to prevent, both acute and chronic complications. So here in America, TrialNet is coast to coast. Our institute participates in it as well, and it's that will screen antibodies if you have a sibling or a parent with type 1 diabetes. The ASP program is done through Colorado, and they'll screen for type 1 diabetes and celiac. ELSA is in the United Kingdom. That's their screening program for type 1 diabetes, and then type 1 screen is in Australia. So again, we have many different screening programs uh, internationally now. And I find this really fascinating because there's been a lot of emphasis on screening and, trying to reduce or pick up patients earlier, reduce hospitalizations, reduce DKA. And back in 2024, Italy passed a law where they're going to mandate screening in their child and adolescent population for both type 1 diabetes and celiac disease. And their hope is that they're just going to truly reduce their hospitalizations and their DKA numbers. So currently, if you catch somebody in stage 2, toluzumab or Tzield is the only FDA approved medication currently. It's a 14-day infusion, and it's been FDA approved for those that are 8 and older. That indication will probably change in the coming months because they've done it in younger patient population, showed safety and efficacy there as well. And in their initial studies, it showed, they showed that they could delay the progression to needing insulin by 2.7 years. So again, that's the only FDA approved medication that's on the market currently. But there are other drugs in research. There's JAK inhibitors that are currently in phase 3 trials, again, trying to delay that progression from stage 2 to stage 3. And then the anti-thymocyte globulin is another prevention study that's going on through TrialNet. So I think that as the world of endocrinology moves forward, we're going to see an immune piece to this as well, where I think we'll probably start prescribing immune modulators to patients to help either delay the need or maybe even continue their honeymoon phase longer. We'll kind of see what the future holds there, but a lot of research dollars are going into immune modulators right now. And why, does this matter? You heard me say that we're trying to prevent DKA. Well, studies have shown us that if in patients who at time of diagnosis are not in DKA, they have lifelong better control, better glycemic control. So this was a study that was published in JDRF, which is now known as Beyond Type 1, a couple years ago, that showed that if somebody was in mild or moderate DKA compared to someone who didn't, the A1C was typically about 1% higher than those who weren't. And if it was in severe DKA, it was over 1% as a lifetime risk. So again, if we can improve lifelong glycemic control, we want to do that. And there's other studies that show, just one episode of DKA can have neurocognitive impact as well. So we want to keep, people's brains functioning to the best of their ability. So if we can prevent DKA, well, hopefully we're having an impact there as well. Stage 3, again, this is just where diagnoses are typically made because again, this sitting on most people's radars when their kid starts, drinking more than normal or, peeing more than normal or start to have nighttime accidents. Again, they just think, oh, something's going on. And then they typically present, in DKA. But and this is the stage where we're starting insulin therapy. I'm also going to mention just the honeymoon phase, um, because this is where we see kind of just improvement in endogenous insulin secretion. So um, when we're running just high blood sugars or hyperglycemic, that hyperglycemia can be toxic to the beta cells that we still have remaining. And as we stabilize and improve blood sugars and get them back in a normal range with insulin therapy, those cells that are still there will start secreting insulin again. So it's very common after diagnosis that we have to reduce insulin doses because people start to have lows. And some people think, oh my goodness, especially if we can catch them early on. Like if it's a lot of times the families, patients who have family members diagnosed type 1 diabetes get caught much sooner than others. And some of those individuals get caught so early that, we might have them on just Lantus only, and no mealtime insulin. Um, but some people think, oh my goodness, those crazy doctors, they miss this. I don't have diabetes because they're reducing my numbers, or they took me off of mealtime insulin and I'm only on long-acting insulin only. Is this type 2? And we always have to tell people that no, the immune mediated response, it will continue, and the remaining beta cells that are there, uh, they will get destroyed, and you'll see insulin needs kind of ramp back up again. So, the honeymoon phase is it's not a cure phase. It's variable for how long it lasts. Some people's weeks, some people's months. Um, but yeah, so some people just, they get a little tricked in this phase thinking that they might not need insulin, but that's not the case when you get that immune process going on. And then again, when you have type 1 diabetes, it's lifelong insulin dependence. A lot of our families that diagnose with us, is there anything else that can be done? And there's just a lot of crazy stuff out there. We've had people ask us about, can we take cinnamon, or can we do this to not have to do this? But no, it's giving back that insulin that's not being made. Uh, and again, we want to talk to our families, and I encourage even the pediatricians on this call, to when they're counseling their patients, encourage them and empower them to take care of themselves daily. So they're not only preventing complications today, but they're also preventing those, decades down the road, complications, because we want our patients to thrive in life, when they're 50, 60, 70, 80 years old. And it takes, doing the little things every day to hopefully prevent those long-term complications. Um, and again, we know that the tighter the control, the less likely complications are to occur. They're still there. The risk is still higher than the general population without diabetes. But again, the tighter the control, the less likely it is to happen. So when you send a patient to us, like you diagnose diabetes in your clinic, you have a kid who comes in, you're like, oh, the blood sugar's 200, but they're complaining of a little nausea, vomiting. We say, okay, send them in, send them to the ER. The first thing that we do is assess for DKA, getting those labs that I kind of showed earlier in the presentation. And then if they're in the DKA, they're going to our PICU for initial management. And if they're not in DKA, we're admitting them to the floor to start subcutaneous insulin therapy and provide diabetes education. I joke with families and tell them, they're going to have to drink from a fire hydrant because they're going to get a lot of information, but we'll get them there. We'll for sure give them the foundation, before we send them out. And it's we have a big team here. Like, our team has docs, educators, nutritionist, we have, LCSWs, we have, exercise physiologists, and the whole purpose of the big team is to work with patients, and, to provide them with the best care possible so they're not only thriving today, but also, years down the road. And then once we get them started on insulin, we break it to them. This is going to be lifelong. And when we start patients off, we're starting with basal bolus regimens or multiple daily injections, where they take a long-acting shot once a day. And then we give them insulin to carb ratios and other formulas to use for how to correct their hyperglycemia. And then a lot of times it's dictated by insurance, but a lot of times we're working towards technology as soon as we can to get them on smart pumps. But when we calculate our doses, it's all really weight-based at first, and then we look at our glucose patterns and then adjust our regimens accordingly, again, to try to get that tight glycemic control. So insulin, is delivered really only through injections or pump. There's no solution, there's no tablet that has been found yet. And so a lot of times, like I said, we start people on injections, and then we're working towards smart pumps to improve their control. I do recommend pumps to my families, but the choice is individualized. To the patient and their family for what is practical and works for them. So I just wanted to show kind of a schematic of one of these smart pumps because I still think there's some confusion as to what's a pump, what's a continuous glucose monitor. So a pump is still, I'm gonna call it somewhat of a bulky device. It looks like an old-fashioned pager or a pod, that sticks off the skin a little way, something that looks like it could hold some type of liquid in it. And pumps come in different fashions. You have some pumps that are tubed, where you'll have an infusion set that runs into the pump, and insulin's delivered through that tube. And then you have some patch pumps, which is just a pod that you fill with insulin and stick on the body that doesn't have that tube. So that's kind of the pump portion. So it's kind of, I think, kind of bigger and bulky. And then the glucose monitors, they tend to be much smaller. They tend to be like coin size. So if you're looking at a device and it looks like, a coin to you, like a quarter, and you think, man, how's that thing holding insulin? If you're thinking if it's holding insulin, it's probably not, and it's probably a CGM, which that CGM, it's the only thing it's doing is just monitoring blood sugar levels every few minutes. And with our smart pumps, CGMs will link to an insulin pump so that the pump knows what the blood sugars are currently and which direction they're trending. And then the pump will make adjustments based on the data it's receiving from that CGM. So a smart pump, if your blood sugars are going declining, it can reduce the amount of basal insulin it's giving you. And if you drop less than 70, it can suspend the pump altogether. And when blood sugars go back up above 70, it'll turn the pump back on. If your blood sugars are staying above your target for too long, a smart pump can give you a correction bolus to kind of help drive those blood sugars back down to that normal range as well. And they can also increase the amount of basal insulin it's giving you if you're staying too high for too long. Now, smart pumps still have no idea what you're eating, so you still have to enter in, what carbs you're eating or consuming, or if you're one particular pump, you have to still make a mealtime announcement to it, so they can give you a bolus of insulin for that food that you're consuming. And then with glucose monitoring, finger sticks is what we teach in the hospital. And then we rapidly try to get people to the continuous glucose therapies where they're wearing those coin-like devices that will look every few minutes at a blood sugar and send it to typically a smartphone. Um, there's data out there that shows just using a CGM alone, even if the person stays on multiple daily injections, can improve their glycemic control. And I'll say that CGMs are increasingly becoming the standard of care as well as smart pumps in our world. And here's just some pictures of some CGM. So again, they're more of coin like devices that you see small. Like I said, that you look at it, you think, I don't think that thing can hold insulin. Um, but yeah, so and there's multiple different types on the market. I mentioned glycemic targets a lot. A lot of times, A1Cs, we check those when we have patients come to clinic. Our goal is to be less than 7 because research has shown us the the risk of developing those micro and macrovascular complications is substantially less if we're less than 7 than above. And in today's world with continuous glucose monitors, a lot of times if you read our notes, we'll talk about time in range or TIR. and that is how much time an individual is spending with their blood sugars between 70 and 180. Our goal is to have patients spend 70% or more of that time in range. There's going to be some lows, unfortunately. We want those to be around 4% or less. And the time above 180, we want that to be 26% or less. So, it's a fine line of what we walk, of trying to, get the most time in range as possible, but also trying to not just have constant, hypoglycemia at the same time. And then nutrition, a lot of families ask about, what diet should I eat, and some people mention like the old term diabetic diet. I think we've went away from that term in the sense that, we want people to eat healthy, well-balanced meals. We want people to eat carbohydrate. We want people to eat healthy fats. We want people to eat protein. It's getting kind of all your macronutrients in moderation. They're going to be a kid. They're going to go to a birthday party. It's okay for them to have a piece of cake. They just need to count the carbs and take insulin for that and eat, a portion size, not, four pieces of cake. But I think, when it comes to just nutrition, it's, the key words that I like to use with family is moderation, and just try to eat healthy, well-balanced meals, making sure we're getting, fats, protein, and carbohydrate, and not just, eating all carbohydrate. And physical activity, again, this is encouraged for all of our patients with diabetes. Years ago, it wasn't encouraged. It kind of it was, I keep people out of sports because the blood sugar swings are too much. But we now know that physical activity improves insulin sensitivity. It also has other benefits for the body in terms of mood, heart health, cholesterol panels. There's a lot there that it can improve. So we want our kids to be active. We want them doing the things that they enjoy doing. There is a risk of hypoglycemia because again, you're more sensitive to insulin during times of activity and even after the activity. So we counsel families on that, and then we can come up with methods for patients as well to try to prevent the lows that may occur during or after physical activity events. And then here I just throw in hypoglycemia because this is one that, scares a lot of families. Uh, and and rightfully so. I mean, low blood sugar causes seizures, coma, and potentially death. So we want to be aware of the signs and symptoms. This is one we want to treat quickly. Having a high blood sugar for 30 minutes isn't going to cause DKA, but a low blood sugar for 30 minutes definitely potentially could cause a seizure depending on how low one goes. So we provide education on the families as to what to look for, how to treat. If we tell them if they're less than 70, we want to eat them some quick rapid sugars to bring it up, and then recheck every 15 minutes until they get above that. We also teach them, emergency medications of glucagon or the nasal glucagon, which is Baqsimi. If they're unconscious or they can't hold, or they're low and they can't hold anything down, like sometimes we have to use in those situations. But hypoglycemia, like I said, it requires the prompt recognition because it can lead to more severe issues more acutely than saying a high blood sugar can. And then with this time of year, with all the flu and RSV and everything else going around, just a few of the sick day rules. Some families want to stop insulin when their kid's sick and not eating, and that pretty much always leads to DKA. So we tell our families to always keep insulin going. A lot of times they're even more insulin resistant during times of illness. So we want to stay on top of giving those injections, giving that insulin back, and checking ketones definitely during times of illness. Because when we even have ketones present, we're more resistant to insulin. And to get rid of those ketones, it kind of takes, giving the insulin to get our body using carbohydrate metabolism again, and then drinking fluids to kind of help flush them out of our system. So we teach all our families how to dip their urine and look for ketones. And then kind of lastly here, just some emerging therapies. We mentioned earlier about disease modifying agents with these, tocilizumab and the JAK inhibitors. I think there's going to be more of those coming on the market in time, and we might be doing more, week long or 2 week long infusions as we catch kids earlier with screening, and even potentially after they're diagnosed to maybe, prolong that honeymoon phase. We're going to see advances in CGM technology and pump technology. There's a lot of people who are looking into non-invasive technology, so using like wearable devices with laser therapies or lasers to kind of monitor your interstitial glucoses that way. I do think in the next 10 years or so, it could be quite possible that people are just putting devices like a CGM that doesn't have a sensor break in the skin. It's just sitting on top of the skin, looking at blood sugars that way. And I think we're going to also see our pumps continue to get smarter with their algorithms to where, carb counting may completely become a thing of the past. I don't know, as we get, smarter or more efficient insulins with better algorithms. So, the world of technology has changed greatly in the last 15 years with diabetes, and I think the next 15 years moving forward will have big changes as well. So our key takeaways, T1D in the pediatric populations is quite common. I'll say last year we had 2,500 visits for patients with diabetes here at our, with our outpatient and hospital. The incidence is increasing both in America and globally. If you have any concern for checking for diabetes in the office, a UA looking for glucose or doing a point of care glucose is a quick, cheap, and easy way to look. Early recognition prevents DKA, and we're really trying to address that moving forward. So hopefully, again, people have better long-term glycemic control, and we're having no negative impacts on their neurocognition. There's these immune modulators that are on the market now, which can delay the need of insulin. And I think we're going to see more of those medicines come to market in the coming years. But again, management still requires lifelong insulin therapy and support. And with that, guys, I'll wrap it up and take any questions anyone may have.
Thanks, Brad. I think that was great. I do see we do have a question in the chat, and currently I don't see any in the Q&A. But question in the chat regarding screening, can autoantibodies be ordered outside of TrialNet or Ask in the United States? Who do you recommend to screen in well clinics and at what age?
Yeah. So yeah, you can order screening any like yes, in Epic you can order the GAD, the zinc, the IA2s, they're all there. I think you have to have a strong reason to screen. I think having a family history of diabetes is a great reason to screen. I think that if you have somebody that has multiple autoimmune conditions, like if you got somebody with celiac and Graves, two or more, I would, consider, especially if they're showing signs and symptoms that could be associated with diabetes. Um, truly obtaining before the age of 2, I think probably wouldn't show you most benefit. Like TrialNet starts their screening at age 2. Most of these screening programs all start at age 2 because it's pretty rare to have autoimmune conditions show up before then. But again, in the world in which we live right now, I think a family history of type 1, looking at that family history slide we showed earlier, makes a lot of sense. And then, like I said, if you got multiple autoimmune conditions, could consider it as well.
Okay, great. Um, I do not see any other questions currently. I know I certainly learned a lot, which is, I guess, is not unexpected for a family medicine trained physician who hasn't treated a kiddo with diabetes in 7 years. So I hope I learned something. Either that or you didn't teach very much. Um, but I very much appreciate it. And I want to thank everyone for joining us today. You'll receive an email with a link to an evaluation for the credit. And please join us for our next update in pediatrics on Wednesday, March 18th at noon. The topic will be pediatric bullying. And thanks for joining us, and everybody have a great week.
All right.
Thank you,
Thank
Brad.
you, guys.